Hello, my name is Dr. Kim Eagle. I'm one of the directors of the Frankel Cardiovascular Center. I want to welcome you to today's webinar. We have a wonderful audience and we are so grateful for your participation. And many of you have been partners in our work, and we're so grateful that you're with us today and also for all that you've done for us. We really appreciate it. Today should be fun. It's going to be a webinar focused on the Michigan medicine and the Frankel cardiovascular response to the COVID-19 pandemic. And we hope that we can inform you about a lot of the work that's been done over these past several months to deal with this challenging time. Today, we're going to be hearing from all four of the Frankel Cardiovascular Center directors. That will include Drs. David Pinsky, Tom Wakefield, and Richard Prager. The webinar is going to last about an hour. You'll hear from each of us, and we'll cover a number of different topics over about 30 minutes. And then we'll have a lot of time, the last half of our hour together, to talk about some questions that a number of you have asked us to cover. You can ask a question through the Q&A function on the webinar, so we encourage you to do that. Please feel free to ask us questions. They will be fed to me, and then I can answer them or direct them to one of the other CVC directors for an answer. This is going to be recorded, so if you want to go back and view this again, or if you want to share it with any of your friends, it will be available to you after we finish the webinar. Today, we're going to first talk about the general response of the Michigan Medicine Cardiovascular Center team to the pandemic. I'll be talking then and asking David Pinsky to talk a little bit about his personal experience on the front lines caring for these patients and some of the unique things that we've done as a cardiovascular center in research. I'll ask Dr. Tom Wakefield to talk a little bit about research continuity during the pandemic, and also the concept of a field hospital. Some of his faculty in vascular surgery have been asked to be ready to stand up a field hospital in our athletic facilities if needed. Then Dr. Prager is going to talk about educational continuity, and he'll tell you a little bit about ECMO, which is a technique that we use uniquely here at the University of Michigan to help our patients. You know, when the pandemic hit, it really changed what we had to do. Michigan Medicine immediately stood up a 40-bed respiratory ICU that could take patients on ventilators. Much of the hospital had to be taken over by patients who had COVID-19. So we completely redeployed our inpatient services. And we moved most of the cardiovascular care over to the patients' centers over in the cardiovascular center. And we opened up some beds that typically are used for recovery, for example. And we had to expand our ability to manage ventilators and the number of ventilators. So we created additional ICU type beds next to the ICUs throughout the main hospital. You know, the response has been amazing. Our trainees, our faculty, our staff, our nurses rushed to the front lines in order to help care for these patients. In addition, because of our unique capability with high-end care, particularly ICU care, the use of extracorporeal support, et cetera, we've taken literally hundreds of patients from other hospitals that came here uniquely for the type of care that we're able to offer. As one of the directors of the Cardiovascular Center, I can't tell you how proud I am of the response, both of Michigan Medicine, our Cardiovascular Center, and all of our faculty, staff, nurses, and trainees. They've been absolutely magnificent during this really unique time in American history. So I want to turn now to Dr. Pinsky, who just came off the inpatient service. David is also our lead champion for some of our research. And I'd like to have David give you a chance to talk about some of these aspects. David?
Thank you very much, Kim, and thank you everybody for joining us. You know, you're all friends of Michigan Medicine and friends of ours, and it's really important that we tell you what we've done. So I'm going to share with you, it's somewhat a difficult personal story. I was just voluntarily self-deployed to the front lines last week, and we see so much on TV, right? So we've been watching it, and it's scary. I'm going to just tell you honestly. I was frightened to death. There was a lot of talk among my colleagues. My colleagues were already taking care of patients, and in many venues. I mean, heroes. I mean, they're hero colleagues. They're hero nurses. They're hero respiratory technicians. We're right there with our coughing patients. But then it was my turn. Putting on that personal protective equipment. Oh my God, there was a checklist, and I went through the checklist 100 times in my head. And then, I put on I washed my hands, and I put on the gown, and I washed my hands, and I put on the gloves, and I washed my hands, and I put on the mask, and then I put on I wiped the goggles down with the virucidal, then I put the goggles on, and then I closed my eyes. I was really, really honestly quite afraid to first enter the room of a COVID patient. And then I closed my eyes, and then I did my own mental checklist. And then I looked at myself, and I looked at my top and my bottom, and am I missing something? And I looked good to go, and I walked in the room. And it was something. When we sign up and we take that Hippocratic oath, we're called, and that's all of us. And it felt like it felt right. And then the patients needed us. We were often the only physician to go into the room. Mind you, the nurses and the respiratory technicians were in there much more than we were, but we tried to keep residents out as much as possible. They stood up heroically when needed. But in the room, then we had to not only take care of the patient and minister to their frail and ailing bodies, but also to their mental health. And I took care of two patients in particular who are about the same age. Both had cardiovascular disease, which, as you might have heard, is a very bad risk factor. And one did better. Thought he had a bad cold. He had a heart transplant in the past, and he just got better. And we don't know exactly why. We did everything we could, and he got better. And the day before I came off service, he went home to his family, and what a great story. And then there was another patient who didn't make it. And it was really sad. And the saddest part about the whole thing is I was able to get, the patient was coherent at one point, and I was able to get his daughter on the phone with his cell phone. He remembered his code. Thank God he knew the code, the password code to his phone, and I was able to contact his daughter. And they had a conversation. It was meaningful. I had been conveying messages back and forth. That was probably the last time he talked to his family member. And then he just got worse and worse. And there's nothing worse than dying alone. So we're seeing that on TV. It's very real, and it's very important for us to be there. We were the family that wasn't family. So it's very real. And then you leave the room with the patients, and then you do the same thing, doffing, which is the taking off of the gowns. That's often where in the Ebola crisis people got infected. And so everything is just very measured, and you close your eyes and you think about it. And then you go home and you shower and you shower and you shower and you shower and you shower, and then you wait and you stay away from your family, and you stay away for a week to 14 days and waiting for something to kick you in the guts. And I'm fortunate nothing did. And I'm so grateful to have been able to be there with my colleagues, many of my colleagues who've done so much more. So what you see on TV is real, and we're very proud at Michigan Medicine to be that. I also want to tell you a story about how we've helped in the Detroit area. We've taken nearly 250 patients. Detroit was hit way harder than Michigan. I think it's important for all of us to know that we were part of this load leveling, and we really took the sickest of the sick. And Michigan Medicine has some very unique things to offer the very sickest patients. Dr. Prager will tell you that about ECMO at the end of this, but that's one of those therapies. So we took about 250 patients from Detroit. I am very proud that Michigan Medicine could help the citizens of the state in that way. So now, what are we doing? We are not victims. We will not be victims. And the Cardiovascular Center is taking a full frontal attack on this. And I'm really excited and proud and pleased. And we're doing that in the way of research, because with research, we're hopefully going to find out why the body fails, how to stop it, how to arrest this virus. And we've got some great leads. So the Cardiovascular Center stood up an Impact Igniter grant fund. And this is where philanthropy matters so absolutely very much. We have the flexibility to immediately attack this disease. And this mechanism was a massive sharing of information between investigators like I've never seen. We've stood up working committees. And so far we've funded 4. We have another 16 that we're reviewing. And the projects are absolutely inspiring. And I'm going to share just briefly a few of those projects. And one of the projects I want to share, if you would put up the slide, Mike, in the background, if you could put up a slide. We had, and I say we because we are all one team, but this is Jason Knight and Yogan Kanthi and many colleagues. Take a look here. This was a Scientific American paper. Now, the original paper was in JCI Insight. It was published in record time, probably 2 to 3 weeks from the time that group got an Impact Igniter grant from us to the time of publication. And what they study is a process called mitosis. It turns out that when you take blood from severely ill COVID patients, one of the things that kills people is they have a bad systemic inflammatory response. The body attacks itself. I've heard it likened on the news to something called friendly fire, right? This is our body's defenses. We all have defense mechanisms to try to protect us. But what if that goes haywire or it's hyperactive? And what you're seeing here in this picture are when these white blood cells, which defend the body against invading marauders, the bacteria that come in, they essentially vomit their contents, which have acids and oxygen radicals and their DNA. That DNA is very sticky and tangly, and it forms spider webs. So if you can imagine, if you all remember I love Spidey, right? He would flick his wrist and then he would shoot spider webs and catch the bad guys. And that's what the neutrophils do. These white cells, they eject these spider webs of DNA, and that's what you see in those green long things. And they normally catch bacteria, but in this case, it's a virus. So rather than catching bacteria, they actually start the process of clotting. And that creates another problem because little clots form in all the blood vessels in the lungs, and the lungs don't get oxygen, and the kidneys fail. So we think that this may be a very important process that injures the body, an overactive defense mechanism, and we might be able to disentangle those nets. And we have some lead therapies, we have some other grants we're considering that is thinking, how do we disentangle those nets? So very exciting. Philanthropy led us to develop these Igniter grants and led us to this new idea, completely original. And then there are many other stories of clotting, how we attack clotting, how we look at men and women. As you know, women are protected. So we have scientists who are trying to study why women are often harmed in cardiovascular disease. Now we're trying to understand why they might be protected. So many, many more stories, and I'm happy to share more in the Q&A if you have questions. But mostly I just want to thank you for being here. Thank you for attending, and thank you for allowing us to be creative and going on a full attack against this scourge.
Thank you, David. It's inspiring to go from being attacked to going on the attack. And a center like ours, coupled with amazing donors like we have, allows us to do that. Richard or Tom, do you want to make a comment before we move on with the next part of our program?
I'm okay, Tom. I'm okay, Kim. I think that was spectacular, David.
Thank you. It feels good to be on the attack.
Yeah.
Really feels good.
Feels good. So Tom, I want to introduce you now. Your faculty are so involved with the notion of how we would handle a big surge that would outstrip the capabilities of our hospital beds. We'd love to hear about that, and also some of your thoughts about how we continue research during this strange pandemic time.
Thank you, Kim. I'm really happy to be here today. The story about the field hospital starts as the projections for the number of COVID-19 patients in southeastern Michigan and for Michigan medicine emerged in the mid to late March. At that time, it was considered by hospital leadership that as many as 1,500 COVID-19 patients may need to be cared for by Michigan medicine. These types of numbers were projected to quickly outstrip our hospital bed capacity. A command center was initiated, and some of our strategic officers were tasked to come up with an option for a field hospital. With considerations for experience in disaster relief and military field hospital deployment, Dawn Coleman from vascular surgery, who's in the Army Reserves, and John Eliason from vascular surgery, who has prior experience in the Air Force, and our Frankel CVC were asked to be part of a core leadership team, among other leaders from nursing, emergency management, and administration. Here you can see in this slide the organization, and you can see Dawn and John in the leadership. A suitable hospital for a field hospital was needed. An on-campus solution was essential, and after investigating many areas on campus, it was decided that the Athletic South Campus Performance Center, the 73,000 square foot newly erected indoor track and field complex, was chosen, and here you can see that complex. The organization of this field hospital effort was immense. Facility modifications, logistics, personal protective equipment provisions, staffing, electronic medical record integration, and other considerations to essentially create a new hospital in less than 10 days were Herculean efforts. In this slide, you can see a diagram created by Michigan medicine personnel and modified by the U.S. Army Corps of Engineers, showing the proposed field hospital layout, with over 500 beds, including 20 high acuity beds and over 425 ward-type beds. Here you see the complexity of the processes needed for creation of a field hospital. This picture shown here is simply the operational workflow to get a COVID-19 patient from the University Hospital to the new field hospital. Keeping in mind that complex efforts such as this workflow are underpinned by distinct but unified components, think about this. You have to bring together personnel and labor, security, clinical operations, logistics and supply, planning and training, as well as communications, internal, external, public, state, and federal. There were more than 100 personnel working on efforts such as these. Fortunately, the field hospital was not needed. And if you look at the final slide, you can see, however, that the efforts of this unified team drafted a field hospital guide that stands ready to ramp up this effort quickly and to care for patients in the state of Michigan should a COVID-19 or other pandemic event occur again. Here you see John Eliason and Dawn Coleman from vascular surgery and the Cardiovascular Center, who were a major part of putting this together, and I believe you can all be very proud of them for this effort. A second effort I wanted to mention is the effort around blood clotting issues with patients who have COVID-19. It's been reported that for patients in the intensive care unit with COVID, 25 to 37% of these patients will have major clotting. And one study from France said that this number was as high as 69%. Now, in many cases, this problem is pulmonary embolism, which is clots that go to the lungs. There are two specific problems with COVID-19 and pulmonary embolism. The first is that the usual way you make the diagnosis is with CT scanning. And these patients are often too sick to be transferred to the CT scanner. And secondly, the biomarker that we use in order to make the diagnosis, called D-dimer, is elevated in patients not because of clotting, but because of the COVID. So we can't use that either. So our vascular laboratory technicians were being asked to do studies in the arms and the legs in order to be a marker for the presence of pulmonary embolism. Well, it turns out that these tests are only about 40% accurate. And so the staff was essentially being asked to do studies that put them at some risk because it takes about an hour of close, intense contact between the staff and the patient to do these studies. So a group of vascular surgeon and cardiovascular medicine specialists along with the vascular laboratory from the Cardiovascular Center came together in order to make a series of algorithms so that we are testing the right patients at the right time and protecting our staff. These algorithms actually are now being used around the country, and they've been published in an article in our Journal of Vascular Surgery. So again, I think you could be extremely proud of the way the Cardiovascular Center came together to solve a problem on the front lines to both give excellent patient care and to protect our staff. The final thing I'd just like to mention is the importance of philanthropy in this period of COVID-19 to our research infrastructure. Many of the research labs had to be essentially shut down during this time unless they were doing specific work related to COVID-19. There are labs that have major contracts and major foundation grants that were about ready to be signed that were put on hold because of COVID-19. And so this is a time when philanthropy can be really important to help these laboratories stand back up when the time comes to make sure that essential personnel do not have to be furloughed or to be released. So I ask you to consider that as you're thinking about your plans to be able to be helpful for our laboratory infrastructure with your philanthropic gifts. And so with this, I'll turn it back to Kim. Thank you very much.
Thank you, Tom. The notion of the field hospital, so important to us. And I hope that we won't have a big surge, and I hope we won't need it. But you and your faculty are just to be commended for helping us think about that. And I think there was even a plan to do this in 2 other locations if the pandemic absolutely did complete overrun. So I want to apologize to the participants that we had some difficulties with the microphone. So you got most of that, and it's fascinating. So we're going to move on now to Dr. Richard Prager, one of the other directors. He's going to talk to us a bit about some of the clinical efforts that we've had, and particularly the use of a technology that was developed here to really help critically ill patients. Rich?
Kim, thank you very much. And I'd like to basically thank everyone on the webinar this afternoon. Thank you for everything and for your support to the Frankel Cardiovascular Center. Let me take a step back and actually expand a little bit on what Dr. Pinsky said about our role being based in Ann Arbor and how we set up to help our colleagues all around Southeast Michigan take care of patients. We created a command center and a new way to transfer patients, and a brief, quick shout out to Stephanie Peters, who's our Chief Administrative Officer, because she actually helped run this with one of the surgeons, one of the general surgeons in the hospital. We actually created a way to bypass the emergency room for some of the sick patients and have them directly admitted to our intensive care units or to our floor units if they were COVID positive. So it saved a lot of steps. Along with that, the other things we did, which aren't really well known, is to set up a separate emergency department. So initially, when we were watching the curve go straight up, we could also have other emergency departments available in West Ann Arbor and at Brighton for bone and joint problems and other people who had emergency problems that were not COVID related. So what this did was allow us to focus on the COVID transfers from Detroit, and there were days that we took 15 to 20 patients from Detroit, most of whom went to directly to our ICUs that we would care for. Actually, just so you have some numbers, Most of our patients came from the Beaumont and Ascension systems, a few from Henry Ford, and actually DMC, since many of you are in the Detroit area, has discharged over 1,500 COVID patients at this time. So if you can take David's very personal experience and expand it to our colleagues in the Detroit area, you know what this experience was like. And as we move specifically to the Cardiovascular Center and what we do, let me first kind of refocus on other missions that we have. And one is to educate the next generation of cardiologists, vascular surgeons, interventional radiologists, cardiac anesthesiologists, and cardiac and thoracic surgeons. While I would tell you that has not been on hold, what it has done is evolve into what's called basically a pandemic training model. All of us learned from our colleagues, especially in Italy, which was overrun for a period of time. Northern Italy, known as Lombardy, created models for care for all of their physicians and caregivers, where you would work 1 week and then have 2 weeks, basically, theoretically, to recover if you got COVID. So the university adopted this Lombardy model. And in this model, basically, that's why David was essentially volunteered to be deployed, but then you're off for a number of weeks. We are just coming out of that model now as the curve has flattened. But our trainees in all of our disciplines redeployed to other areas. We were doing less operations. So Tom and I and the cath lab and interventional radiology, we all basically were only doing people who needed to be operated upon or have a procedure done, who was frankly a threat of life and limb, or that they were predicted to have a problem within 5 days. Otherwise, our procedural areas, including operating rooms, were shut down. So our residents' education became an education in remembering the Hippocratic Oath, as David mentioned, as well as many of them volunteered for the COVID ICUs, other ICUs, as well as rounding at night and taking up roles of other providers, including our nurse practitioners, PAs, and other providers. So the physical aspect of training new cardiac surgeons has basically been put on hold for this period of time, which will have an effect, but we know it can be made up for, we believe, in a brief period of time. The other realities I would add to is why some of these patients were transferred. Many of them were transferred who were acutely ill, and the typical support, including ventilator support and rotating patients, and you may have read about this, where patients were turned prone or on their abdomen for a while they were intubated on a ventilator or back on their back. And if this was starting to fail, and it did appear that these patients were ones who might benefit from another technology, ECMO was considered. We are the major ECMO center in this, frankly, in this part of the country. And if I could have the diagram, Mike, I can tell you a little bit about the history of this very briefly. Over on the right part of that, the left part of the slide, with the gentleman with the vest and the striped tie, which must be maize and blue, is Bob Bartlett. Many of you have heard of him. Bob trained in Boston and was in California in practice and was a cardiac and thoracic surgeon, who basically, the woman in the middle of that was a newborn who was placed on ECMO. That is the first successful ECMO newborn patient in the world, Esperanza. Bob and Esperanza are still in touch. Ted Colabel invented a membrane oxygenator, which was actually used. So let's focus on the middle two frames, if you will, of this diagram. These are both ECMO, extracorporeal membrane oxygenation. So you need a system where we take blood outside the heart with one of those cannulas. It goes through a pump, and that's the little pump to the left of the sign that says lung, and then it's put into a lung, an artificial lung, which was actually the silicone membrane oxygenator, and goes back to the right side of the heart. So basically, your lungs can rest. This takes the place of lungs. All right, that's VA ECMO and VV ECMO. The VA ECMO actually is the heart and lungs. The VV ECMO is basically just the lungs and is cannulated, or the cannulas are placed in the body differently. The majority of patients, and we have currently today have 9 patients on ECMO. 5 or 6 of them are actually for COVID, and others are for other disease processes. We have had patients weaned off of VV ECMO in our hospital already. They have not been discharged yet. The average ECMO patient for other diseases, including the H1N1 epidemic that we were a part of, are in the hospital about 55 days. So none of the patients who have come off ECMO have been discharged yet. We do anticipate it. The age range for us has been from teenager to about 65. Around the country, and we can take the slide off now, around the country, the majority of patients are under age 65 and do not have any significant dramatic comorbid conditions. So with that, I would echo what everyone has said, and I believe that Michigan Medicine, as with all the other hospitals in our area, are all working hard and deeply committed to handling this pandemic and doing it in the best way possible. We are also sharing technologies and concepts with the physicians at all the other hospitals in our areas so that we can basically attempt to apply the best approaches to all of this. So with that, Kim, I'll stop there.
Thank you, Richard. Wonderful history of Dr. Bartlett and a technology developed here that's really used now around the world to help really critically ill patients, and how ironic that those patients are now coming back here to get a technology that was developed here many decades ago. So now we get into the part of the webinar that I'm going to enjoy the most, and that is the Q&A period. And our webinar participants can send a Q&A. You can send a question to us if you'd like. And I'm going to go through some of those and serve those up to the various directors for an answer. David, one of the people asked us how individuals can help at this unique moment in our history.
Well, there's so many ways to help, but what we've done as an organization is consolidate efforts for a COVID-19 fund, a philanthropy fund, and that will go to the area of most pressing need. And it's a very fluid situation, and it might be research, it might be care, it might be something that we need, but that's a very important and growing opportunity to help in the way that it's most urgently needed.
Thank you, David. Tom, one of our participants asked me a question, and that is, when we're sort of in lockdown mode, what are some of the things that we should be thinking about in terms of preventive health when we're home?
Thank you. Well, of course, washing hands frequently is very, very important, and keeping social distancing is very important. For those who need to be on cardiovascular protective medications, statins, antiplatelet agents such as aspirin, medications for blood pressure control, all the experts suggest, and we suggest, that you should stay on those medications. You should try to exercise. You should try to stay as healthy as you can, so that your immune system is as robust as it can be possible. Basically just try to stay in as good health as possible to protect yourself, but wash those hands.
Great, thank you. And try to get your fresh fruits and vegetables too, along with your exercise. Richard, one of our participants asked us if patients who've had heart surgery are at higher risk. What's your reaction to that?
So my quick answer to everyone is that frankly, I'm not sure you're at greater risk unless you have other cardiovascular issues, perhaps hypertension, perhaps dramatic arrhythmias. But just because you've had an operation should not necessarily put you at more risk, especially for years ago. That said, we do know the risk profile, certainly for the sickest of patients, usually starts with obesity, frankly, as well as diabetes, and then cardiovascular diseases, if you will.
Thank you, Richard. I suppose if you have a normal heart muscle after your heart surgery and the blood flow to your heart is good, then some of the risk might have been mitigated by a successful prior operation, I suppose.
Yeah, I would agree with that, Kim.
David,
can I just want to interject one thing. There's been a lot of chatter or concern about several medicines, primarily used to treat blood pressure, but often in many types of heart disease. And the advice we're always giving is, first of all, talk to your doctor, but we don't think people should be stopping their heart medicines. I know it's confusing because in the press, there's concern, but what we know is they may either help you or they may not help you, and we don't know. We are studying it, but in the meantime, keep going with your medications and speak to your doctors.
Thank you, David. You anticipated one of the participants who asked the question, if I'm on an ACE inhibitor or an angiotensin receptor blocker, what's the deal? And there were two studies actually released this week. One, I think, of 1,100 patients and another 1,700 patients, which suggested that patients who are on these antihypertensive drugs who are in hospital for COVID don't do any worse than patients on other types of drugs for hypertension. In fact, one of the studies suggested they might do a little bit better. So the research would suggest that you're right. Our patients should stay on these agents unless there's a compelling reason to come off. David, while you're up, one of the participants asked us about if you have a history of an arrhythmia, does that put you at special risk?
So that doesn't appear to be a unique risk factor. Now, if that heart rhythm disturbance is due to something like heart failure, then I might change that answer. But in general, no, it doesn't. I think anybody who has advanced age, who has heart disease, hypertension, those things are known risk factors. And what would be the advice? Social distancing, wash your hands, don't touch your face, all the things you're hearing, and just be really mindful of that. But no, heart rhythm disturbances don't appear to confer higher risk.
Thank you. Tom, one of the participants asked whether or not the COVID-19 virus affects the arteries of the heart or the arteries or veins of the body. What would you tell them?
You know, initially it was thought that the virus really just attacked the epithelial cells in the lung. But actually it's been found on autopsy studies, unfortunately, that it has to be an autopsy study, that you can see remnants of the virus in many different vascular territories, such as the kidney, the vessels in the kidney. So I do believe that the virus attacks many different cells and many different organs. It does that through what you've heard about these spike proteins and through a receptor on the cells. And we don't know whether, for example, the patients who have kidney problems with COVID, whether it has to do with the fact that the virus has gotten into the cells and then essentially the cell becomes destroyed and the material then gets into the microcirculation and blocks it, or whether it's a response to the immune mechanism that you heard about earlier, where inflammatory cells become activated in really a hyperimmune state, and then that leads to changes in the kidneys and the heart, for example. So we also know that COVID patients are very hypercoagulable. They tend to make clots much more than patients who have other disease processes.
Thank you, Tom. A couple of our participants asked questions that I think are relevant to cardiac injury. One of them asked whether there were any specific pathologic markers of infection of the heart muscle with COVID-19. And we do know there are certain proteins that are released when the heart muscle is injured, but at least up until now, there's not a specific marker yet that we've identified. But this is an area of intense study for scientists in our center. They're very interested in identifying markers of cardiovascular injury and risk so that we potentially could even use that for prognostication or potentially even treatment. Another participant asked whether COVID-19 has a lasting effect on cardiac health. David, what would you say to that question?
I say it's a bit too early to tell. We do know there can be some injury of the heart muscle itself in an inflammatory process called myocarditis. In other conditions, that is often reversible and time will heal. I think this is just too new a virus to us to say for certain, but I can tell you, I pray and hope that there's healing to make it through the acute period.
Yeah, it's interesting, isn't it, that they're calling this a novel coronavirus because it is truly novel. And we don't know the long-term consequences on various organs that are affected and whether it will affect downstream prognosis. Obviously, lung injury, is there a permanent decrement in lung function? All of these things are waiting to be determined. But our center perhaps is uniquely positioned with the talent that we have here to ask and answer many of these questions.
Yep.
David,
matter of fact, in that vein, we've stood up these working groups, and one of our working groups in the Cardiovascular Center is the inflammation myocarditis immune aspect working group, and they're working feverishly to try to understand this intersection between the immune system and the cardiovascular system.
And it's so fun to watch scientists from across our campus gathering into teams to attack this common enemy. And also our center working with other centers both in this country and abroad. I don't think I've ever seen in my lifetime more of a fever for collaboration to push the science as fast as we possibly can. It's really inspiring to watch. David, I want to ask you a question. One of our patients is waiting for a pacemaker battery replacement, and he's been put on hold. Tell us when we might be able to start doing things like that.
Okay, that's a very good question. And this doesn't only affect a procedure like replacing a battery in a pacemaker, but many of our somewhat elective procedures. Well, we stood down on anything that wasn't acutely emergent, as Dr. Prager said. And the reason was we didn't want to bring people into our system who might then catch COVID. And the risk of catching it might have been higher than the risk of the somewhat elective procedure. So that's where we were. Where are we now? We are going in reverse. We have testing. Our pathology laboratory has done a terrific job being able to do a lot of tests. We're at the point now where every inpatient will have testing. And by May 4th, actually, everybody who comes in for one of these procedures will be able to be tested. So we will make our patients safe. We will make our staff safe. And so the answer is we did have to stand down on some of these things that can wait. And for pacemakers specifically, we have a record of, it's called end of battery life, and we can know when, with just a magnetic device over the pacemaker, when that might be. And so people generally have time. It doesn't just go kerplunk stop. There's time. And so our doctors will measure that, and know that there's safety in waiting a few weeks. But we are now ramping up and going back towards our more normal. It'll be a while. It'll be, a month or two to really unwind the stopping and do the starting. But we are doing that actively.
Thank you, David. Richard, one of the participants asked a question, what have we learned that will apply if there's a resurgence later this year or next year?
I would start my response to that by saying that, frankly, we anticipate a resurgence. Two, that when we added over 100 more ICU beds, we have made plans as well to keep an additional 50 beds open for COVID regardless. We are at less than 100 COVID patients today, and hopefully in a week or two, we're down to 50. They will be segregated into an expanded ICU. We will keep this open, and it may have a second area that we keep open as well if you don't need ICU care. So one thing is we've learned we can expand services, and we have many, many dedicated people who are comfortable working in those environments. We've also learned how to approach a pandemic as the background, how to approach taking care of everyone. Virtual visits, streamlining the ability to get to see us. So the new patient that calls tomorrow, or more likely next week, will get a virtual callback and visit, a video visit within 48 hours to set up the most appropriate time and easiest place for them to go. So I have to admit it, we've realized we weren't very efficient. But that is perhaps one of the few good takeaways from this. And we've also learned, as David and Tom have talked, to use the fundamental science that people are evolving to care for patients in a tertiary quaternary facility like ours and do it as well, if not better, than other people can.
Can I make an added comment there?
Please.
One of the things that Rich was saying was about the hospital and how we stood up these new intensive care units. As many, maybe all of you know, we're right now in the process of building a new inpatient tower, which we're very proudful and very needful of. It's a really important project. One of the decisions we took about a year ago in our planning was to make every single bed in that hospital convertible into an intensive care bed. Now, the plan wasn't to make them all intensive care beds, but it was just to prepare for the future in that way. And that did actually add expense to the build, but we as an organization said we need this capability. Little did we know how much we need this capability, because we are converting lots of places to ICUs that weren't maybe initially designated, or they didn't have the oxygen hookups and all the things, the negative airflows that make them. But we are doing that really at significant expense in our new inpatient tower. And just to tell you that, boy, we need that now more than ever.
Right.
And then, remember that we are ready now with a field hospital if that is needed. So
exactly. Yeah.
Easy to come by.
I've been impressed that the pandemic has created a firmer basis of the team, that both how we use our facilities collectively and how we govern them, how we imagine virtual care at a place that hadn't done much of that. This is all a new day. And in some ways, perhaps you learn the most when you're most challenged. And I feel like all of our teams have learned a lot, and we'll be much better prepared if there's a resurgence in the fall or next year. David, one of our participants asked about how we share our research. He was intrigued by the paper that you showed by Dr. Canty and asked the question, how do we get this light to shine to other places that are dealing with COVID-19?
Oh, it's a great question. We've decided purposefully that we will be in an era of hyper transparency, uber transparency. So we're doing things different. Like, for instance, often scientists in their laboratories sort of cloister and keep their ideas a little private till they can zoom on the scene with publications. We're now putting out preprints before peer review even, so that the germinal ideas get shared. We have many forums for sharing information across our colleague institutions, across America and across the world. And so we're doing that. From the Cardiovascular Center, we've also created a stand-up website. Normally, when an application for funding it gets reviewed. It's kept secret until it gets funded. So those applications which don't actually make the funding bar really are private. And what we've said is no. If you're going to apply for this kind of funding, we're going to share the ideas across the board, and maybe investigators can find like-minded investigators, cross-fertilized disciplines. So we have now a website at the Cardiovascular Center. Any of you can take a look at that site. It shows what we're doing, what we're funding, even ideas which are germinal in nature we are sharing, because we think that will be the wellspring for new ideas. So yes, you can look at our website. We have all these other forums, and sharing, transparency.
Richard, one of our participants asked the question, if they have a coronary stent, are they at greater risk?
I think I would echo what David said about risk factors. I'm not sure they should be, other than the decision about what agents to take for anticoagulation, especially with what Tom said about COVID and the clotting disorder that can occur. But I think the reality is, no, you stay on your standard medicines, you do what you do, and hopefully you are walking 3, 4, 5 miles a day or doing the right things for your health. And as we all have said, not everyone gets COVID, and I think you just have to follow your medications. It's a different story if you have COVID, as David has explained, but not everyone will have cardiac issues, even if they do get COVID.
Excellent. There's a question about appointments. One of our participants said, why do you have to schedule routine appointments so far out? What's your answer to that?
We won't have to anymore. So I have the opportunity to sit at a department chair meeting, and we have had these meetings during COVID 5 or 6 times a week, and have all collaborated about the reality of enhancing our clinical systems. And part of that will be virtual, part of that will be initiatives to open doors at least 6 days a week for visits for everyone throughout the health system. We have already been doing that. Cardiovascular medicine has done that for a few years. It's going to be expanded throughout the health system. I think for all the people on the webinar, you will see a much more facile health system come out of this.
Yeah, it's really interesting. It sort of took a crisis for us to get better in this space. I had a call about a patient in Florida and another one from Grand Rapids. I've scheduled them both for a virtual visit next week. And it's completely changed, I think, our ability to imagine providing care to patients both near and far. And it's going to be better. It'll be better for having gone through this. David, one of the participants just asked this question. Why did we have to stop elective operations? Wasn't there a way to kind of isolate people to one part of our facilities so that we could keep going the way we were? How did you answer that one?
Yeah, well, that's a great question. First of all, this came on us like an explosion. And our first plan was actually to do just what was suggested. We call that cohorting of patients. We were going to have all of the non-COVID patients in one part of the hospital, all the COVID patients in the other. But first of all, there was a problem because we weren't able to get testing up as quickly as we wanted, so we weren't always certain. And the testing that we had doesn't show whether you might have had an exposure in the last day or so. And so one of the issues initially was testing. The second issue was PPE. That's the personal protective equipment. By the way, I do need to pause 1 minute. Some of you, many of you in the group actually sent in generous donations of PPE. I might have been wearing that when I was on service. Thank you. We haven't, honestly, it's happened so quick, we haven't had the time to say thank you directly to everybody, but I'm telling you, it mattered. But so the second issue was, first was testing, second was PPE. We didn't want to consume our PPE supply, which was quite limited. We're doing better now, but at that moment it was quite limited. Doing something elective when the people who were taking care of the crashing patients on the front lines needed that PPE. And so that was a strategic organizational decision. If something can wait, that would wait. So it's keep the patients safe, don't put them in an environment where they may catch it. And with the explosive growth, that became hard, and protect the PPE supply so that providers on the front line could provide the care they need in a safe environment.
And I think part of it too was the notion that if you can't routinely test, patients who feel perfectly well, or faculty or staff who feel perfectly well, might be shedding the virus.
Absolutely.
And so until we had the capability to do more testing, which we now have, we were worried that people who felt fine might be sharing the virus back and forth, patient to provider. Right. And that was a big deal.
There was one other facet of that, and I just try to imagine this. It boggles my mind, my imagination. We turned the entire hospital upside down. So the nursing staff, the assistant staff, people who would normally assist in those elective procedures, they were deployed. They were deployed to the hospital. We turned our entire hospital into a COVID caring hospital. That's how we turned on a dime to do that. So staff from the outpatient area were redeployed to the inpatient area. Staff from the operating rooms, from anesthesia, were deployed to our critical care units. And that massive redeployment of human capital really was another feature in having to stand on some of the electives.
And I would just, Kim, if I could, and David, the reality is we all learned from New York, Italy, other places, what they had to do essentially to survive. And we've all seen the newscasts from a month ago, 6 weeks ago. And so we were prepared for the worst, really, in how we redeployed and how we organized. And elective procedures, or even, if you will, more urgent procedures, it was felt most appropriate to hold on all that, to protect the patients and to be prepared for, fortunately, what didn't totally occur to us.
And if I could just add that we went from having approximately 100 ICU beds in Michigan Medicine in total to over 250. And we didn't increase staff for those 250 beds. So those 250 ICU beds then had to be run by our existing faculty, nursing, and ancillary staff. And so you can see that we needed to redeploy folks because of the fact that we increased our ICU capacity tremendously in a very short period of time.
We redeployed our equipment too. For instance, we took ventilators out of the cath lab and out of the EP lab where they normally live, and we gave them to the ICUs. So everything, personnel, equipment, everything was redeployed.
David, do you think it's worth having antibody testing? People out there?
I absolutely love the idea of antibody testing. We're still uncertain as to whether antibodies confer a long-lasting immunity. My personal sense is yes, they will, and they have to. And we actually have a research project now looking at other types of antibodies. And yes, antibody testing is important. It's gone a little bit slower because what we're finding, our pathology group who've done an outstanding job, are finding that some of the testing and the reagents aren't reliable and reproducible. I think we have narrowed in on a rapid reproducible assay, but that's taken some time. The quality control in Michigan Medicine is really important.
So one last question. One of the participants asked about wearing masks, and I think for the moment at least, we're likely to be wearing masks in places where we're within 6 feet of individuals until we're pretty sure the virus has dialed down, and then hopefully we'll gradually see things opening up. And I've been experimenting with various masks, and the Block M mask, I feel most secure when I'm wearing the Block M. and hopefully we'll have these available to our participants.
Kim, does that block and tackle virus?
That blocks COVID, baby. That blocks COVID. I want to thank all of the directors for your participation. I want to thank the team that helped produce the webinar. And I especially want to thank the participants who dialed in today. This is obviously a new journey for us. We had a little technical glitch. I'm sorry about that. I'm sure we'll get better. And this is a way that we can keep you abreast of all the work that we're doing. And we're at the end of our hour, but I want to thank you again for participating, and please stay safe and stay well. Thank you very much.
Thank you. Go Blue.
Thank you.